Trauma and stressor-related disorders occur when individuals experience a stressful or life-threatening event that leads to long-term psychological distress. Example is a soldier returning from war, but who still feels like they are in danger when they hear fireworks, or a child who experienced abuse and now struggles with forming relationships as an adult. These are common outcomes of trauma. Not everyone exposed to trauma develops post-traumatic stress disorder or other stress-related disorders. However, when symptoms interfere with daily work life or relationships, professional intervention may be necessary. Before we move forward, let's define some key terms that will help us understand trauma-related disorders. We have post-traumatic stress disorder or PTSD. This is a disorder where individuals experience flashbacks, nightmares, and severe anxiety after a traumatic event. We have acute stress disorder or ASD. This is similar to PTSD, but symptoms occur within the first month after trauma. We have dissociation. This is a mental process where a person feels disconnected from themselves or from reality. And we have reactive attachment disorder. This is a condition in children where they struggle with forming emotional bonds due to early neglect. What exactly is trauma? Trauma is any event or situation that overwhelms a person's ability to cope. It often leads to intense fear, helplessness, or horror, and can have lasting emotional effects. Here are some real-life examples of trauma. We have personal trauma. For example, is a survivor of domestic violence who has trouble feeling safe in relationships. Another one is collective trauma. Example is a community affected by a mass shooting or a terroristic attack. We also have the sudden loss. A person who loses their entire family in a car crash may experience extreme grief and PTSD. Each person processes trauma differently. While some recover naturally, others develop long-term stress disorders. There are three main types of trauma. One, we have acute trauma. This results from a single traumatic event. Example is a person who experiences a home invasion and afterward feels anxious about being alone. We also have chronic trauma. This involves repeated exposure to trauma over time. Example is a child growing up in an abusive household who may develop difficulty trusting others and suffer from depression. We also have complex trauma. This occurs when multiple traumatic events happen over time, often starting in childhood. Example is a person trafficked as a child who later develops severe PTSD, depression, and trust issues. The type of trauma experienced plays a big role in how individuals cope and recover. Not everyone who experiences trauma develops PTSD or another stress-related disorder. However, some factors increases a person's risk of long-term mental health effects. We have genetics. Some people have a genetic tendency to develop anxiety or depression after trauma. If a person has a family history of PTSD, they may be more vulnerable after experiencing trauma. Then there is early life trauma. This is experiencing trauma in childhood and can have a lasting impact on brain development. A child who is repeatedly neglected may develop attachment issues and struggle with relationships in adulthood. There is also the severity of trauma. The more severe and prolonged the trauma, the greater the risk. A survivor of prolonged torture or captivity may struggle with PTSD for years. Another one is the lack of social support. Having no support system increases the risk of mental health struggles. Example, a soldier returning from combat who has no family support may feel isolated and unable to cope. Identifying high-risk individuals early allows for timely intervention to prevent long-term mental health problems. Think about a person who has survived a car accident or a natural disaster like a typhoon. Even though the event has passed, they may continue to have nightmares, anxiety, or flashbacks when they hear loud noises or see a similar setting. This is an example of how trauma can affect mental health long after the event. Post-traumatic stress disorder, or PTSD, is a major concern in our nursing practice, especially when caring for trauma survivors, military veterans, and victims of abuse. Understanding PTSD helps us nurses provide compassionate, evidence-based care to improve patient outcomes. PTSD is not just stress or sadness after a traumatic event. It is a serious mental health condition with well-defined symptoms. According to DSM-5, PTSD is diagnosed when a person has been exposed to a traumatic event. Second, feels extreme fear, helplessness, or horror. Third, experiences persistent, distressing symptoms for more than a month. It is important to recognize when PTSD symptoms start to affect a person's daily life and encourage them to seek professional help. Did you know that up to 60% of people who experience a traumatic event develop post-traumatic stress disorder? PTSD can affect anyone, regardless of age, gender, or background. But there are several high-risk groups. This includes first responders, such as firefighters, paramedics, police officers. We also have healthcare workers. These are nurses who work in the emergency rooms or the intensive care units and are constantly exposed to death and trauma. There are also military personnel. These are soldiers and those medics who are assigned during combat. Included in the high-risk groups are disaster survivors, such as typhoon, earthquake, and flood victims. PTSD does not always appear immediately after trauma. Some individuals develop symptoms weeks, months, or even years later. Some people first develop acute stress disorder or ASD, which lasts between 3 days to 1 month. If symptoms persist beyond 1 month, PTSD is diagnosed. Not everyone who experiences trauma develops PTSD. Some people recover quickly while others struggle for years. There are several factors that increase a person's risk of developing PTSD. We have the severity and duration of trauma. The more extreme and prolonged the event, the higher the risk. Second is the proximity to trauma. Direct exposure to life-threatening situations increases risk of PTSD. Third is the lack of social support. Having no support system after trauma makes it harder to cope. Fourth, we have history of mental illness. People with anxiety, depression, or past trauma are more at risk. Fifth is the repeated exposure to trauma. First responders, military personnel, and abuse survivors face recurring traumatic experiences. A classic example is a Filipino nurse working in an intensive care unit during the COVID-19 pandemic may have developed PTSD due to witnessing countless patient deaths, prolonged stress, and lack of emotional support. It is important for high-risk person groups to be assessed early and be encouraged to avail of strong support systems and also to be educated on PTSD prevention strategies. What are the symptoms of PTSD? These symptoms are grouped into 4 categories. We have re-experiencing symptoms, wherein the patient experiences flashbacks, nightmares, and intrusive thoughts. We also have avoidance symptoms. This is when the patient avoids trauma-related places, conversations, and emotions. Third are negative mood symptoms such as guilt, hopelessness, and emotional numbness. Fourth are hyperarousal symptoms. This is the person always feeling on edge, with difficulty sleeping or presenting with irritability. What are re-experiencing symptoms? This is one of the most distressing PTSD symptoms. How this happens? This includes intrusive, distressing memories, like the person keeps reliving the event. Also, flashbacks. The person may feel like they are back in the moment. Also, nightmares. The trauma keeps repeating in that person's dreams. And severe distress at reminders. A sound, smell, or place can trigger intense emotion. Example is a soldier returning from a combat zone and may have flashbacks and panic attacks when hearing fireworks, as the sound reminds him of gunfire. Many PTSD patients go to great lengths to avoid anything that reminds them of their trauma. Common avoidance behaviors include avoiding places, people, or conversations about the trauma, refusing to think about or process the event, and numbing emotions to avoid pain. PTSD often changes the way people think and feel about themselves, others, and the world in general. Common negative thoughts include self-blame, even when they have had no control over the situation. This includes frequently saying, "It was my fault." Also, another negative thought includes a constant state of fear and mistrust, such as feeling that the world is not safe. Another negative thought is the feeling of isolation and being disconnected, like saying, "No one understands me." Another negative thought is losing motivation and feeling emotionally numbed. This could present as a lack of interest in life. Example is a Filipino rape survivor that she may believe that she will never be safe again, thus will refuse to leave her home. Hyperarousal symptoms make post-traumatic stress disorder patients feel like they are constantly in danger. These symptoms include irritability and anger outbursts, hypervigilance or always being on high alert for danger, exaggerated startle response such as jumping at loud noises. These also include sleep disturbances such as insomnia or nightmares. How is PTSD diagnosed? PTSD is not diagnosed immediately after trauma. Symptoms must be present for at least a month and must interfere with daily life. DSM-5 diagnostic criteria for PTSD include symptoms lasting more than a month. The person experiences significant distress or impairment, and at least one symptom from each category of re-experiencing, avoidance, negative mood and cognition, and hyperarousal. Not all trauma-related stress reactions turn into PTSD. Some individuals develop acute stress disorder or ASD first, which may or may not progress into PTSD. The key differences between acute stress disorder and post-traumatic stress disorder include ASD being having symptoms that appear within 3 days to 1 month after trauma. These symptoms often resolve on its own with time and support, while post-traumatic stress disorder symptoms lasts more than 1 month and may and always require professional intervention. What are the impacts of PTSD on life? PTSD doesn't just affect mental health. It has long-term consequences on daily life, relationships, and physical well-being. How does PTSD affect our life? Number 1, it affects our personal relationships. PTSD can cause trust issues, emotional withdrawal, and difficulty maintaining relationships. It could also affect work performance. PTSD can lead to difficulty concentrating, absenteeism, and decreased productivity. PTSD can also affect our mental health risks. This includes having a higher risk for depression, substance abuse, and suicidal thoughts. PTSD alters the brain's structure and function, making it difficult for individuals to process trauma in a healthy way. There are three brain areas affected in post-traumatic stress disorder. We have the amygdala, which is our fear response center. The amygdala becomes overactive, leading to excessive fear and anxiety. It also affects our hippocampus, our area for memory processing. There are going to be struggles to distinguish past trauma from present reality. And then another area affected in PTSD is our prefrontal cortex. This is the area that is known for our emotional regulation. The prefrontal cortex in PTSD has shown decreased activity, making it harder to control fear response. PTSD is a universal disorder, but different cultures express distress in different ways. There are several cultural factors that affect PTSD. 1. The expression of symptoms. In some cultures, PTSD manifests as physical symptoms such as headaches, dizziness, and body pains instead of emotional distress. Another one is stigma. In Asian cultures, including the Philippines, discussing mental health is often taboo, leading many to suffer in silence. Another one is the coping mechanisms. Some cultures rely on spiritual healing, traditional medicine, or family support instead of seeking therapy. A Filipino farmer who survived a typhoon may not describe their PTSD as anxiety or depression, but instead say, "Nawawalan ako ng gana sa buhay," or "masakit lagi ang ulo ko." What are the different treatment of PTSD? The good news is PTSD is treatable, and with the right approach, patients can regain control over their lives. Effective PTSD treatments include psychotherapy or talk therapy. This helps patients process trauma and develop coping strategies. Other PTSD treatments include medications used to reduce anxiety, depression, and nightmares. Also, there are holistic approaches. Mindfulness, relaxation techniques, and exercise help manage symptoms. Cognitive behavioral therapy, or CBT, is one of the most effective treatments for PTSD. It focuses on how thoughts, emotions, and behaviors are connected and helps PTSD patients change negative thought patterns that keep them trapped in their trauma. Many PTSD patients develop irrational beliefs about themselves and the world after trauma, making it difficult to heal. CBT challenges these thoughts, teaches healthy coping strategies, and helps patients regain control over their lives. CBT challenges irrational thoughts. One of the biggest struggles for PTSD patients is the negative, distorted thoughts they develop after trauma. When irrational thought says, "I will never be safe again," CBT rephrase this to, "I survived and I am learning how to stay safe." Irrational thought like, "It was my fault," CBT reframes this to, "I did the best I could and I deserve to heal." irrational thought such as, I am weak because I can't move on. CBT reframes this to, healing takes time and seeking help makes me strong. CBT helps patients identify, challenge, and replace these irrational thoughts with healthier ones, reducing guilt, self-blame, and fear. CBT teaches healthy coping skills. PTSD often leads to avoidance behavior, like patients avoid people, places, and situations that remind them of trauma. However, avoiding triggers reinforces PTSD. CBT helps patients face their fears gradually and safely, so they learn to manage emotional distress rather than escape from it. CBT also teaches patients stress reduction techniques such as deep breathing and mindfulness, journaling to process emotions, and progressive muscle relaxation to reduce physical tension. These skills empower PTSD patients to regain control over their emotions instead of being overwhelmed by them. CBT improves daily functioning. PTSD often disrupts everyday life. People struggle to concentrate at work, avoid social situations, and feel emotionally disconnected from loved ones. CBT encourages small, positive behavioral changes that make daily life feel manageable again. CBT helps PTSD patients take back control over their routines, relationships, and personal goals so they can live a fulfilling life. As nurses, our role in CBT includes encouraging PTSD patients to participate in this therapy. Remind them that their thoughts can change and healing is possible. Nurses can also reinforce CBT coping strategies. This will help patients practice deep breathing and relaxation techniques. Also, nurses can support gradual behavioral changes, such as reminding them that small steps leads to big improvements in life. One of the most common symptoms of PTSD is avoidance. Many patients avoid people, places, and situations that remind them of their trauma. While avoidance provides temporary relief, it actually makes PTSD symptoms worse over time because the brain never learns how to properly process the trauma. This is where exposure therapy comes in. Exposure therapy gradually and safely exposes PTSD patients to their trauma triggers, helping them face their fears in a controlled way. By slowly confronting trauma-related memories, situations, and emotions, patients learn that they no longer have to live in fear. The first and most important step in exposure therapy is creating a safe and supportive environment where the patient feels in control. Therapists work with the patient to set clear goals. That is, exposure is never forced and the process happens at the patient's own pace. Patients learn grounding techniques to help them feel stable and calm before starting exposure exercises. The therapist reassures the patient that they can stop or slow down at any time if the exposure feels overwhelming. Exposure therapy does not involve relieving a trauma all at once. Instead, it follows a step-by-step process where patients face their fears in a controlled way. Step 1 is indirect exposure. The patient talks about the trauma, reads about similar events, or watches related videos. Step 2, controlled real-world exposure. The patient visits locations associated with the trauma or engages in activities they have been avoiding. Step 3, full exposure. The patient gradually regains confidence in facing trauma-related situation. Example is a car accident survivor who avoids highways. He or she may start by looking at photos of highways, then watching traffic videos, and eventually riding as a passenger before driving again. This slow, structured process helps the brain realize that the past trauma is over and the person can feel safe again. Exposure therapy can be emotionally intense, so patients learn coping strategies to manage their anxiety while confronting trauma triggers. These coping strategies include deep breathing exercises, grounding techniques, and progressive muscle relaxation. As nurses, we support our clients during their exposure therapy by ensuring that they are gradually exposed. We encourage small, manageable steps rather than forcing them to face their biggest fears immediately. We can also teach relaxation techniques that help our patients, such as breathing exercises and mindfulness, to stay calm. We can also provide emotional reassurance. We can remind PTSD patients that exposure is not about relieving trauma, but about reclaiming their confidence and sense of safety. Exposure therapy helps PTSD patients break free from avoidance and fear, giving them the confidence to live their lives fully again. For many PTSD patients, traumatic memories feel as intense and real as when the event first occurred. These memories are not properly processed, which is why they keep triggering flashbacks, nightmares, and emotional distress. Eye movement desensitization and reprocessing, or EMDR, is a structured therapy designed to help PTSD patients reprocess traumatic memories in a healthier way so they no longer feel overwhelming. Patients follow specific eye movements or stimuli while recalling traumatic memories. EMDR is different from traditional talk therapy because it focuses on bilateral stimulation, which helps the brain reprocess distressing memories more effectively. During EMDR sessions, patients are asked to recall a traumatic event while following specific eye movements, sounds, or tapping exercises guided by a therapist. This stimulation helps shift the way the brain stores trauma, allowing patients to process it in a less distressing way. Patients do not have to describe their trauma in detail. They just need to focus on how they feel while recalling the memories. Number 2, the brain processes trauma more effectively, reducing emotional distress over time. Trauma affects the brain in a unique way. When a person experiences something highly distressing, the memory may get stuck in the emotional part of the brain, which is the amygdala, rather than being properly processed by the rational part of the brain or the prefrontal cortex. EMDR helps unstick these memories, allowing the brain to reprocess them as past events rather than present threats. While therapy is the main treatment for PTSD, medications are often used to manage symptoms, especially when they interfere with daily life. PTSD medications help with reducing anxiety and panic symptoms, improving sleep and decreasing nightmares, and stabilizing mood and preventing depressions. There are 4 main types of medications used for PTSD. 1, we have the selective serotonin reuptake inhibitors, or the SSRIs. These are the first-line treatment for PTSD. These include Prozac, Paxil, and Zoloft. They work by increasing serotonin levels, which helps regulate mood and anxiety. This will benefit patients with depression, anxiety, and intrusive thoughts. A patient may also be given serotonin norepinephrine reuptake inhibitors, or SNRIs, which includes venlafaxine. These SNRIs increase both serotonin and norepinephrine, thus improving emotional stability. This is often given to patients with both PTSD and chronic anxiety or depression. Another medication given is prazosin. Prazosin is used for PTSD-related nightmares. This medication blocks adrenaline's effect on the brain, reducing nightmares and improving sleep. This benefits PTSD patients with severe sleep disturbances and night terrors. In severe cases, atypical antipsychotics and mood stabilizers are also given. This includes Seroquel and Risperdal. They are used in severe PTSD cases where standard medications are ineffective. This benefits patients who experience severe mood swings, aggressions, or psychotic symptoms. As nurses, we play a critical role in the care and recovery of patients with post-traumatic stress disorder. Our responsibility goes beyond giving medications. We need to provide emotional support, education, and practical coping strategies to help patients regain control over their lives. Here are key nursing interventions for PTSD. 1. Establish a safe, therapeutic environment. Know that PTSD patients often feel unsafe due to their constant state of fear and anxiety. Provide a calm, non-threatening environment where they feel comfortable. Use active listening and therapeutic communication. Many PTSD patients feel misunderstood or judged. Avoid phrases like, "You should move on." Instead, say, "I understand this has been difficult. How can I support you?" Teach grounding techniques to manage flashbacks and anxiety. Grounding techniques help PTSD patients stay in the present moment when they feel overwhelmed by flashbacks or panic. Encourage deep breathing, mindfulness, and sensory grounding exercises. For example, we can assist a patient with PTSD by teaching the 5-3-2-1 technique. We direct the patient to think of 5 things that they can see, 4 things they can touch, 3 things they can hear, 2 things they can smell, 1 thing they can taste. This helps redirect their focus away from the traumatic memory. Encourage social support and connection. Isolation worsens PTSD symptoms, so building strong social connections is essential. Encourage patients to reconnect with trusted friends, family, or support groups. Educate patients on PTSD and treatment options. Many people don't understand PTSD or think they should just get over it. We teach patients about their symptoms, triggers, and how therapy and medications can help. Self-care strategies for PTSD patients that we can teach them to develop. These help patients regain control over their emotional and physical well-being. 1. Practice mindfulness and relaxation techniques. Mindfulness helps patients stay grounded in the present instead of reliving past trauma. Encourage activities like meditation, deep breathing, and guided imagery. 2. Maintain a healthy lifestyle. Exercise regularly. Physical activity releases endorphins that reduce stress and anxiety. Eat a balanced diet. Nutrient-rich foods support mental and physical health. Also, encourage patients to get enough sleep. Fatigue worsens PTSD symptoms. 3. Engage in creative outlets and hobbies. Creative activities provide emotional release and a sense of accomplishment. Encourage developing or pursuing any relaxing hobby such as painting, writing, music, or gardening. 4. Set realistic goals and avoid overwhelming stress. PTSD patients often feel mentally drained, so guide them to set small, achievable goals. Encourage to break tasks into manageable steps to avoid feeling overwhelmed. 5. Seek professional help when needed. PTSD can get worse without proper treatment. Encourage therapy and support groups. Remind patients that asking for help is a sign of strength, not weakness. What are our nursing role in encouraging support systems? We educate patients on the benefit of social support. We encourage them to reconnect with family and friends, and we refer patients to PTSD peer support groups or counseling groups. PTSD is a serious but treatable condition. With the right combination of therapy, medication, nursing care, and self-care, patients can regain control over their lives. Again, don't forget that PTSD is a real and serious mental health condition and not just stress or weakness. Early intervention is crucial. Nurses play a role in recognizing PTSD symptoms. Treatment works. We have CBT, medications, and exposure therapy help patients heal. And nursing care matters. Offering them a safe, compassionate environment makes a difference. Then self-care and social support are essential. We help PTSD patients build strong support networks. As nurses, let's remember that empathy, patience, and understanding are just as important as medical knowledge when caring for PTSD patients. We have the power to offer hope and healing. Dissociative disorders is a fascinating and complex group of psychiatric conditions that disrupt consciousness, memory, identity, and perception. Understanding these disorders is crucial for our nursing practice, as they often manifest in individuals with a history of trauma or extreme stress. Dissociative disorders involve a disruption in consciousness, memory, identity, or perception. These disruptions are not due to substance use or any medical condition, but are instead psychological responses to extreme stress or trauma. Think of dissociation as a psychological escape mechanism. When someone experiences traumatic event such as abuse, violence, or war, the mind sometimes disconnects from reality as a way to cope. This is similar to how people zone out or feel detached during high-stress situations. But in dissociative disorders, this reaction is prolonged and significantly impairs daily life. For example, a person might suddenly forget personal information or feel as though they are watching themselves from outside their body. In severe cases, individuals may even develop entirely separate identities. The onset of these disorders can be sudden or gradual, and they may last briefly or become chronic. Now let's take a look at the different types of dissociative disorders. We have the dissociative amnesia. This is characterized by the inability to recall important personal information and is often related to trauma. This amnesia is too extensive to be explained by normal forgetfulness. A specific type, called dissociative fugue, occurs when individuals unexpectedly travel away from home and assume a new identity with no recollection of their past. They may suddenly wake up in another city with no idea how they got there. A classic example is a case where a woman disappeared from her home in New York and was found months later in California. living under a different name and identity. Previously known as multiple personality disorder, dissociative identity disorder or DID is perhaps the most well-known yet controversial dissociative disorder. It is characterized by the presence of two or more distinct personality states, often referred to as alters. Each alter may have a different name, age, voice, and even mannerisms. These personalities take turns controlling the person's behavior and may have gaps in memory between switches. DID is often linked to severe childhood trauma, particularly repetitive abuse. One famous case is that of Sybil, a woman who reportedly had 16 different personalities, each with unique characteristics and memories. Although later questioned, her case brought significant attention to DID. The depersonalization or derealization disorder involves persistent episodes of either feeling detached from one's self or depersonalization, or feeling that the environment is unreal, or derealization. Patients often describe feeling like they are watching themselves from outside their body, or that the world around them seems distorted, dreamlike, or artificial. Unlike psychotic disorders, individuals with this condition remain aware that their perceptions are altered, but they cannot control it. For example, there was a college student who has been under extreme stress during exams, and she suddenly felt as though she was observing herself from above, as if in a movie. The primary cause of dissociative disorders is psychological trauma, often during early childhood. It could include severe physical or sexual abuse. Many patients with DID, for example, report histories of prolonged abuse, which led to the mind doing what you would call as fragmentation as a coping mechanism. Or during combat, natural disasters, or severe accidents. This can also trigger dissociative symptoms in adults. There were controversies in the diagnosis. Some professionals believe that DID is overdiagnosed due to suggestibility in therapy, while others argue that it is underdiagnosed due to a lack of awareness. The main form of treatment for dissociative disorders is psychotherapy, which includes reassociation therapy. This helps patients integrate dissociative memories and identities. Cognitive behavioral therapy, or CBT, is used to help individuals manage anxiety and recognize maladaptive thoughts. Group therapy. This provides social support and reduces isolation. There is no specific medication to cure dissociative disorders, but drugs like antidepressants and anxiolytics can help manage depression and anxiety that often accompany these conditions. As nurses, we play a crucial role in the care of patients with dissociative disorders. A thorough assessment should include cognitive function and memory recall. Does the patient experience gaps in memory? Emotional support. Are there signs of anxiety, depression, or anger? Behavioral observations. Are there indications of identity switching or dissociation? Nursing interventions include ensuring safety. Patients with dissociative disorders, particularly those with trauma histories, may be at high risk for self-harm or suicide. Always assess for suicidal ideation. Use grounding techniques. Encourage patients to stay connected with their present surroundings. Simple techniques include holding a cold object, touching textured surfaces, or describing the environment aloud to bring them back to reality. Build emotional support. Teach relaxation techniques, journaling, or mindfulness to help patients manage dissociation. Educate families about recognizing dissociative episodes and responding with patience and reassurance. For expected outcomes in the short term, we aim to reduce anxiety and distress through coping strategies. Improve sleep patterns and self-awareness. In the long term, success is measured by the patient being able to express emotions and memories in a healthy way, and the patient learned or developed the ability to function in daily life without significant dissociation. With the right care, individuals with dissociative disorders can achieve stability and improve their quality of life. To summarize, dissociative disorders arise from trauma and disrupt key aspects of consciousness, memory, and identity. Treatment focuses on therapy, symptom management, and coping strategies, while nurses play an essential role in ensuring safety, providing emotional support, and teaching grounding techniques. Understanding these disorders help us provide compassionate, evidence-based care to patients who have endured severe psychological distress.